did at ESMO, at the virtual ESMO Congress, I presented the first results of CheckMate 649, which is a worldwide randomized phase 3 study on nivolumab plus chemotherapy versus chemotherapy as first-line treatment for advanced gastric cancer, gastro-oesophageal junction, and esophageal adenocarcinoma. As you know, standard first-line chemotherapy in this disease results mostly in less than 1 year. Nivolumab provided superior overall survival versus placebo in the ATTRACTION-2 study in heavily pretreated advanced gastric cancer. Additionally, nivolumab and chemo showed promising anti-tumor activity in first-line chemotherapy in the ATTRACTION-4 study. Now, PD-L1 expression by a CPS cutoff of 5 or higher has shown enrichment for efficacy with checkpoint inhibitors in studies before. Our trial I presented is the CheckMate 649, which had 3 arms. There was one arm which is nivolumab plus ipilimumab, that is immunotherapy alone. This will be reported maybe next year, since this part is still closed and blinded. What I reported at ESMO is the 2 arms on chemotherapy, Xelox or Folfox, plus minus nivolumab, in 1,581 patients. 60% of these patients were PD-L1 CPS 5 or higher. CPS is the amount of PD-L1 positive cells, not only tumor, but also in the tumor microenvironment, lymphocytes and macrophages. I reported on the dual primary endpoints, overall survival and PFS, progression-free survival. The baseline characteristics in both arms were well consistent and well balanced. Mostly non-Asians and patients with metastatic disease were included. With regards to duration of treatment, the patients who were treated with nivolumab plus chemo had a longer duration of treatment with around 7 months versus chemotherapy with only 5 months. Disease progression in around 2/3 of all patients was the most common reason for treatment discontinuation. Now I come to the overall survival, which was the first primary endpoint. The overall survival was highly statistically better for nivolumab plus chemo versus chemotherapy alone, with 14.4 months for nivo plus chemo versus 11.1 months for chemotherapy alone, with a hazard ratio of 0.71, a p-value of 0.0001. So that was highly statistically significant. Since you cannot see the Kaplan-Meier curves, I just described them. 11% of patients had higher 1-year survival, which was 57% with nivo plus chemo versus 46% with chemotherapy alone. And the separation of the Kaplan-Meier curve was continuous and from the beginning to the end of the Kaplan-Meier curve. Again, always around 10% difference from the beginning to nearly 3 years. However, at the end of the Kaplan-Meier curves, there is still not yet fully unclear, since we still have to wait for later and longer median follow-up. Now, with regard to the overall survival of the CPS 1 or higher, and all randomized patients, again, the median OS was in favor of the nivo plus chemo, and again, statistically significant, with a hazard ratio of 0.77 versus 0.8 in all randomized patients. With regard to progression-free survival, again, in the primary population with CPS 5 or higher, there was a highly statistically benefit with median PFS from 7.7 for nivo chemo versus chemo with 6.0 months. So again, hazard ratio of 0.68, statistically significant with p-value of 0.0001. So taken together, the PFS benefit was seen in all subgroups. And with regards to the subgroups for overall survival, there was also a clear favorable prognosis for patients with Nivolumab plus chemo across multiple pre-specified subgroups like region, eco-performance status, or primary tumor location, but also MSI and MSS. Overall survival consistently favored Nivolumab plus chemo. Okay, so with regard to response and duration, there was again a clear advantage with Nivolumab plus chemo, with a response rate of 60% with the combination versus 45% with chemotherapy alone. So that means 15% benefit of response with chemo plus Nivolumab. Again, the duration was clearly longer in the patient subpopulation with CPS 5 or higher with the combination Nivo plus chemo. With regards to safety, there was no new safety signal. And additionally, the treatment-related adverse events were numerically higher for Nivo plus chemo, but the risk-benefit ratio was also favorable for the combination. With regards to treatment-related adverse events with potential immunologic etiology, according to organ subgroups, most of them were low, and grade 3-4 events of immunologic etiology occurred in less than 5%. There were no grade 5 events. So taken together, Nivolumab is the first PD-1 inhibitor to demonstrate a superior overall survival and progression-free survival in the combination with chemotherapy versus chemotherapy alone in previously untreated patients with advanced gastric, gastro-oesophageal junction, and esophageal adenocarcinoma. There was a clear, highly clinically meaningful overall survival benefit in these patients, particularly for CPS 5 or higher, but also for CPS 1 and higher and all randomized patients. And there was a statistically significant benefit for the PFS. Therefore, I concluded at ESMO, and I'm very confident that Nivolumab plus chemotherapy represents and will present a new potential standard first-line treatment for patients in this disease. Yes, of course, since we don't have all biomarkers tested and also many additional analyses we need for approval at FDA and EMEA, the analysis will go on, particularly for MSI, MSS, for other subgroups like TMB and so on. And then we hope soon to have this combination approved by the authorities for our patients.